Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 112, Blood Clot Prevention and Treatment. I'm excited to bring you this episode. It's a topic that I had been just starting to turn over in my head following the episode on travel. I suddenly realised I've never done an episode on blood clots, thrombosis. And around the same time, two of my listeners had the same thought and got in touch asking me to cover this topic. And the reason I'm excited is because one of them that got in touch, Megan, is a student midwife, and the other person that got in touch, Maria, is a pregnant woman. I like to think my podcast reaches both maternity staff and women using our services. So it was with real joy that I discovered in the same week, two of my listeners from those two different groups got in touch asking about the same topic. So I'm really hoping that this will be a really useful episode. So what are we talking about here? We're talking about blood clots, thrombosis. And it may sometimes feel a little like in maternity we're obsessed with the chance of developing blood clots. We'll ask you seemingly random questions at the start of pregnancy to try and score your chances of developing a blood clot during your pregnancy or after the baby's born, and to decide whether we need to give you some preventative treatment. One of the reasons for this is that thrombosis, blood clots, particularly deep vein thrombosis, which are clots in the deep veins of the leg, usually starting in the calf and then extending further up the leg, are more common in pregnancy. And this can lead to pulmonary embolism, that's blood clots on the lungs, and this can be life-threatening if left undiagnosed and untreated. More rarely, women can also develop blood clots in the veins in their brain, something called cavernous sinus thrombosis. And this is less common. The reason for obsession with blood clots is that although they're rare, they are a significant cause of maternal death. If you look at the most recent Embrace report from 2021, they remain the most common direct cause of maternal death. By direct, we mean something that is related specifically to the pregnancy. But don't get frightened. Blood clots will occur in 1 to 2 per 1,000 women. And one of the reasons we're very focused on them is they're an entirely preventable cause of maternal complications and death. So if we're vigilant, we should be able to massively reduce these numbers. So why do pregnant women get blood clots? Pregnancy is what we call a prothrombotic state. The way I describe it to women in clinic is their blood is a bit more sticky. It's a bit more likely that a clot will form. Okay, sticky blood. That just won't hack it for some of you, I know. But actually, that's all I kind of need to know in my day-to-day work. But if I go back to my textbooks, then actually it's because there are increased levels of several clotting factors. So the blood clots by what's called the clotting cascade. And this is composed of platelets, little cells that help the blood clot, and various proteins called clotting factors. And they interact with each other to form a clot. So from the first trimester, from the first third of pregnancy, a lot of clotting factors, 1, 2, 7, 8, 9 and 10 are increased. And then immediately after delivery, 5, 7 and 10 increase further, which could account for the fact that we see some blood clots more commonly after pregnancy. So this is one of the reasons blood clots are more common in pregnancy. The other thing is it's more difficult for the blood to return from your legs. There's raised pressure in your abdomen when your baby's developing and you've got a large womb full of baby placenta and the water around the baby. And this puts pressure on your veins and you get what's called venous stasis, so less good return of blood from your legs and pelvis up to your heart. Okay, that's what we're talking about. That's the kind of medical detail. So every pregnant woman is more at risk of a blood clot than if she hadn't been pregnant. For some women, the risks are significantly higher. And this is why we're asking you all these weird questions. Some of the factors that make blood clots more common will remain the same during pregnancy, such as your age or perhaps an underlying clotting condition in your family. But other factors may change as the pregnancy continues, such as your weight, whether or not you smoke, whether you've got varicose veins. So we need to constantly be reassessing what your risk is. And as your risk changes, look at whether or not you need to have any treatment. The main times we'll do this check and risk assessment is when you book in with the midwife at the very beginning of pregnancy, at 28 weeks when you're entering the third trimester, if you're admitted to hospital, and when you're in labour and immediately after you've had your labour when we're transferring you to the postnatal ward. So these are the kind of fixed points where a midwife or doctor will have a look and try and figure out what are your risks, what are the chances of you developing a clot, and do we need to do anything to try and prevent it? But there will be other points in pregnancy when actually we may need to review things. Maybe you've developed a new condition such as preeclampsia, or maybe you've been unfortunate enough to have an operation for some reason, or an accident and you've maybe broken your leg and been more immobile. It's really important that we listen to women when they're telling us what they're doing. I myself have been at fault when a woman told me she wasn't walking around much and had very reduced mobility, that I didn't clock the fact that actually her risk had changed and she had a much higher chance of a deep vein thrombosis than I'd initially assessed. So reviewing this chance constantly and talking to the woman is really important. It's tricky. When you look at the reports, 90% of women having a pulmonary embolus, that's the clot on the lungs, will have underlying risk factors. Okay, that sounds easy. All the women with risk factors, we just can focus on them, can't we? Well, let's consider what's our baseline. How many women will have risk factors? Whoa, 50% of women will have risk factors. That's a bit more tricky. And certainly, as the population of women having babies is getting older, anyone over 35 gets a point on the risk scale for that, or more overweight, anyone with a body mass index of more than 30 gets a point for that. It adds up quickly. Therefore, we're seeing more and more women that we need to think about blood clots and blood clot prevention. And this was the question that Megan got in touch about. We're doling out more and more prescriptions of anticoagulants. And here's the difficult bit. In pregnancy, this means injecting yourself every day, or possibly even twice a day. And to ask a woman to do that for the whole of her pregnancy, or for the several months at the end and then 6 weeks after she's had her baby, is a big ask. Many of the drugs that are used to anticoagulate and make the blood thinner are not suitable for use in pregnancy or when breastfeeding. So when I prescribe preventative treatment, I'm really conscious I'm asking them to do a very difficult thing. Yes, the syringes come pre-packed. Yes, they're very easy to give yourself. But actually, injecting yourself every day, or asking your partner or family member to inject you every day, and putting up with a needle every day, that's a big deal. So we have to be conscious when we ask that, and we have to make sure that the woman really does feel able to take this on and do this, because there's no point us prescribing it if she's actually not going to manage to take it. So prescribing, this is one of my main bugbears. We have to, in obstetrics, do all the prescribing. Now, this doesn't make any sense to me. We're often told we need to prescribe because the prescription needs, and I quote, specialist monitoring. Specialist monitoring that the GP cannot provide. To me, this is totally nonsensical. What monitoring am I doing? Well, the answer is pretty much nothing. Yes, of course, I'll see the woman, I'll talk to her, I'll make sure she's okay, I'll explain the reasons why we might be prescribing it, and I'll see her on a regular basis. But the idea that we're monitoring anything is false. It clearly says in the guidance that there's no need to monitor either factor 10A levels, which check whether the injections are actually doing the job they're supposed to do, or platelets, because one of the side effects can be a reduction in platelets. And in terms of support and advice from our haematology colleagues who deal with blood clots outside of pregnancy, well, they'd be inundated. They'd have so many women to see that they can barely cope. So, specialist monitoring by the hospital? Not really. And I'm certainly not doing my GP colleagues down. It isn't their fault. I suspect the underlying issue is more about the cost of the prescription and the stock, whether our pharmacy have it in comparison to community pharmacies. So I'm sure it's much more these days about the practical arrangements and the cost than it is about the clinical supervision. In this way, COVID has actually been a bit of a blessing because I can now prescribe electronically, and women that I see or that have a phone appointment with me can pick up their prescription locally rather than having to come trekking into the hospital just for a prescription. It's important we get the treatment correctly prescribed in terms of dose, because the dose of treatment will depend on weight. And one of the comments in the last Embrace report was actually the need to re-weigh women during pregnancy to ensure that we're giving them the correct dosage. The other point at which this can become confusing is the difference between preventative treatment, known as prophylaxis, or treatment dose, where you're actually treating an existing blood clot. So it needs to be thought through when we're prescribing. What are we prescribing for? Are we prescribing to prevent a clot, or are we prescribing to treat a clot because they're both weight dependent, but they're both totally different. And what about your choices in labour? If you're taking antenatal anticoagulants, does that mean you have a much bigger risk of bleeding? Well, certainly if you're on treatment dose, so high dose, you've actually had a blood clot during your pregnancy, then yes, potentially you are more risk of bleeding. But on the whole, what that actually means is we need to try and minimise all the other causes of bleeding for you. And if you're taking your medication twice a day, 12-hourly, we'll try and pause it because you're not going to get a blood clot in the perhaps day that you don't take your medication because you're in labour. So usually if you're in the early stages of labour or we're planning an induction or a caesarean, we'll tell you to stop your treatment. Of course, labour's often unpredictable, so you may not be able to do that. And in that case, the only issue is it affects your choices about pain relief. It's important that you shouldn't have an epidural or a spinal anaesthetic within 12 hours of the dose of anticoagulants. And this is because of a very rare complication called a vertebral canal hematoma. This is where you get a small blood clot where you had this spinal or epidural, and this puts pressure on your spinal cord and causes neurological damage. It's incredibly rare, but that's what people are worrying about when they're saying you can't have an epidural or a spinal within 12 hours of your dose. Anyone who's been unfortunate enough to experience a blood clot, whether that's in their leg or in their lung, will have a plan made by the multidisciplinary team. So that should include the anaesthetists, the haematologists and the obstetricians, so that all these eventualities are thought through in advance for spontaneous labour or planned birth, whether that be induction or caesarean. Of course, it depends slightly. If you had your blood clot in early pregnancy, by the end of pregnancy, it may be that you don't need much special treatment at all. But if you're having your blood clot late in pregnancy, particularly in the third trimester, when treatment will not have been completed, then it's important to have a very thorough planning session antenatally so that everyone is clear what they need to do to keep you and your baby safe. So Maria asked me, if I can have an epidural or spinal 12 hours after my dose, does that mean my anticoagulants aren't actually working at that point? And the answer is yes. It's not something I'd thought about till you'd asked me the question, but I've looked it up, and actually the half-life of the effect of Fragmin, which is the most common anticoagulant we use, is actually between 2 and 4 hours. So if the half-life is 2 to 4 hours, by around 8 hours it'll be a quarter, and by 12 hours it'll be an eighth. So the effects will gradually dwindle over time between doses. So what we're doing is giving you a dose every day to prevent a blood clot developing. So it's not that your blood is thinned all the time, it's that we're doing enough so that a blood clot won't build up and develop. And the way the treatment works is by acting on one of those clotting factors that I talked about. And if you're on treatment dose and we're giving it twice a day, what that actually means is that it's more frequent that your blood is not clotting, and therefore not only will blood clot not build up, but existing blood clot should hopefully dissolve. So we'll usually recommend that you give birth on the labour ward. And again, a bit like my episode with low platelets, is this actually a sensible plan? I mean, if a woman actually can't have a spinal or epidural because she's recently taken her anticoagulation, then actually we probably want her on a midwifery-led unit so that she's more mobile and less likely to need that sort of pain relief, because she's less likely to need intervention. So there could be an argument for giving birth in an alongside midwifery-led unit, even though this, strictly speaking, doesn't meet the guidance of a midwifery-led unit, and therefore you'll need to talk to your consultant or your consultant midwife and discuss an individual birth plan. So I would say birth centre, absolutely as good as labour ward. Home birth, probably not the best plan if there is an increased risk of bleeding, but again, something for you to discuss individually with your team. If you have treatment doses and you've actually had a clot during your pregnancy, then that's completely different. I would definitely say you need to birth your baby on your local obstetric unit, but that doesn't mean that you couldn't have many of the things that would be provided to you in a birth centre. For example, we've got a pool on our labour ward. You can use birthing balls, you can use mats, you can be active. And one of the things we need to remember about blood clots is that actually keeping women well hydrated, mobile, and we give you those really lovely sexy green support stockings called TEDs, prevent you from getting a blood clot. One of the main points from the recent Embrace report, as well as the issue about weighing women and prescribing the correct dose, was also to try and improve a scoring system that is a bit easier for everybody to understand, as well as to make sure that if women were being in hospital for a period of time, many of us have difficulties with women waiting for perhaps an induction of labour, that we need to be vigilant and make sure that women who've stopped their anticoagulants to have their baby are not stopped for an excessive amount of time, but are prioritised so that they're off their treatment for the minimum amount of time. The other thing that's important is to make sure postnatally, remember I said postnatally is a higher chance time for blood clots, is to make sure women actually understand the importance of taking their injections and how to do it. If a woman's staying in hospital for a very short time, she may not even have the first dose before we leave if we're not on top of our game. And then we do actually need to make sure they're taking it. Megan's question was that we're seeing increasing amounts of use of anticoagulants on the postnatal ward. And I totally agree. We're prescribing more than ever before. Remember, I said increasing maternal age, increasing obesity, and also, let's not forget, increasing caesarean rates. But equally, I've also seen more postnatal deep vein thromboses recently than I ever remember seeing in my career. And these are potentially avoidable. So despite all this treatment, we're missing some. So then I'd think about the question, are women actually taking what's being prescribed, and have we really explained to them the importance of doing so? I remember hearing a fabulous speaker at an event a couple of years ago, pre the pandemic, and I'm really sorry I can't remember who she was, otherwise I would definitely credit her, as she was inspiring. What she recounted was a project with local women. She noticed when she was doing her community midwife visits that women had boxes of injections on the shelf unused. So she noticed that women, yes, they had their prescription, yes, they went home with their injections, but no, they weren't actually using it. And she went round and collected all these injections and took them into her local hospital. And she described bin bags full. Bags and bags of prescribed and unused injections. And not only is this a terrible waste of resources, but actually it's the woman not having the confidence or the motivation to inject herself or get one of her family to do it. So we need to think about how much we're educating women about the importance of this. How are we using primary care, GPs, health visitors, and community midwives to understand the importance? What about if you have an actual clot? We do a lot of tests, a lot of investigations to look at actual clots. We might start with scanning your leg with an ultrasound scan, similar to the ultrasound you have of the baby. And that's to look and see whether the veins are patent. Is there blood flow in the veins? Or we might do a chest x-ray to look at your chest if you come in with shortness of breath. We can't see a pulmonary embolus on a chest x-ray. The reason we're doing one is because one of the most common alternative diagnoses is actually a chest infection. So if we do a chest x-ray and we see clear signs of an infection, then we can prescribe antibiotics and we know it's much less likely that it's going to be a blood clot. So as a precaution, because we know blood clots are very worrying, you may be admitted to hospital if you come in saying you're breathless or you've got a bit of a swollen leg, and we'll put you through what seems like a massive barrage of potentially unnecessary tests. Well, that's because if we miss a blood clot, it's potentially life-threatening and serious. But in my experience, those women that do have a serious blood clot in pregnancy, actually the diagnosis can be pretty obvious from a clinical examination. I've certainly seen women with a deep vein thrombosis extending all the way up their leg. Their leg is swollen, not the normal kind of pregnancy swelling. It's significantly more swollen than the other one. It may be red, it certainly will be hot to touch, and it will be painful. It will look usually very different to the other leg. Of course, there are always exceptions, but on the main part, it'll be obvious. And to some extent, it's the same with a pulmonary embolus. Women that are a bit breathless, otherwise feeling okay, maybe their heart rate's up a little bit, on the whole, don't usually have a blood clot. But a usually fit woman who suddenly can barely exercise, is gasping for breath, and drops her oxygen saturations the minute you get her to walk up and down the corridor, that's the woman that has a pulmonary embolus. And it can happen to fit, healthy, not overweight women that seemingly do not have many risk factors. You only need to look at Serena Williams, the professional tennis player who had a pulmonary embolus after having her daughter, to understand that. When we're doing tests to look for blood clots, there's a test called a D-dimer that we will usually use outside of pregnancy. In pregnancy, it's useless. It's raised anyway. It's really unhelpful. So that's why we have to rely mainly on imaging. So we'll usually start with a chest x-ray and a leg Doppler, leg ultrasound. But then we'll work our way up, if we're suspecting a clot on the lungs, to what's called a CTPA. That's a CT scan of the pulmonary arteries, or a VQ scan. That's a ventilation perfusion scan. And these tests, it depends a little bit on what the hospital has easy access on, and also what that radiologist would like to do and what that woman would like to do. Both a VQ and CTPA have a slightly increased risk of childhood cancer because of the radiation. And a CT scan also has a slightly increased risk of breast cancer for the mother, again, due to the radiation. So we need to explain this to women and consent them for that. But if you have a good going pulmonary embolus, a blood clot on your lungs, that is a life-threatening condition. And if we're really suspicious that that's what you have, then it's very important, despite these very small increased chances of safety concerns for you and your baby, we really need to go ahead. Because if we diagnose it properly and treat it properly, you and your baby will be safe. Now, this is a massive topic, and there's absolutely no way I can cover it comprehensively. If you look in the programme notes, you'll immediately see there's not one green top guideline on this topic from the Royal College of Obstetricians and Gynecologists. There's 2. That tells you just how massive a topic it is. There's 37A and 37B. So my zesty bit is, if you're a professional, make sure that when you're talking to a woman about blood clots, that she understands why it's important and why you might be recommending something. And if you've prescribed something, is she comfortable taking it? And is she actually taking it, particularly after the baby's born, when she's having less appointments, less checkups? Does she know that actually that is potentially the danger period? So make sure, as with many of the things I discussed, that you're educating women. And if you're a woman, then try and help us. If you think you've gained loads of weight during pregnancy and you might need reweighing and your dose recalculating, let us know. If we're telling you that you've got a number of risk factors and we think you need some preventative treatment, understand why that is. No, you don't have to have it. It is absolutely a choice, as with everything else in your maternity care. But understand why we're worried about you and understand what are the other things you can do, such as exercise, keeping yourself well hydrated, and not increasing your risks with other activities like long journeys and travel that I talked about. If you're breathless, if your leg is swollen, if you're worried, get in touch with your local maternity team, because this is a completely treatable, preventable complication of pregnancy. And if you want to know more, I've also attached a really nice patient information leaflet from the RCOG, which will tell you a bit more about what you might want to know. I very much hope you found this episode of the theobspod interesting. If you have, it'd be fantastic if you could subscribe, rate and review on whatever platform you find your podcasts, as well as recommending the theobspod to anyone you think might find it interesting. There's also tons of episodes to explore in my back catalogue, from clinical topics, my career and journey as an obstetrician, and life in the NHS more generally. I'd like to assure women I care for that I take confidentiality very seriously and take great care not to use any patient identifiable information unless I have expressly asked the permission of the person involved on that rare occasion when it's been absolutely necessary. If you found this episode interesting and want to explore the subject a little more deeply, don't forget to take a look at the programme notes where I've attached some links. If you want to get in touch to suggest topics for future episodes, you can find me at theobspod on Twitter and Instagram, and you can email me theobspod@gmail.com. Thank you for listening.